Welcome to the Virtual Education Chronic Pain Summit Series Part 2, presented by Johns Hopkins University School of Medicine. My name is Dr. Joseph Riley, and you are tuned into the live session titled, How is Chronic Pain Different in Women, and What are the Management Implications, with Dr. Roger Fillingim. Dr. Fillingim is a professor at the University of Florida College of Dentistry in Gainesville, Florida, where he is also the director of the Pain Research and Intervention Center of Excellence. Before we get started, I'd like to remind our audience that we will be taking questions in real time throughout this presentation. You can send me your questions anytime during the program through the box on the lower left-hand side of your screen. Dr. Fillingim?
Well, thanks very much, Joe, and thanks to all of you for joining in for today's session on chronic pain in women, including a discussion of the management implications. You can see there on the slide my disclosures. And the learning objectives for today's session are that upon completion of this course, the learner will be able to, first of all, describe the nature of gender differences in pain and analgesic responses, and second of all, apply knowledge of these gender differences to the practice of pain management. And I'd like to start by just highlighting 3 different case scenarios that we'll return to later in today's session. The first case is Terry, a 54-year-old presenting with fibromyalgia and mild depression. The second case is Chris, a 27-year-old presenting to the ER with a long bone fracture after a motorcycle accident. And the third case is Pat, a 48-year-old presenting with chronic recurrent low back pain. You may have noticed that these names are gender neutral and the sex of the patient is not mentioned. I bring these cases up to highlight that you may already have suspicions about the gender of each of these cases, which suggests that you're already using gender-related information in your workup and potentially in your management of patients. And we'll return to this issue later in the session. For an overview of the presentation, I'm going to start with some conceptual issues, and then we'll head into more content-related issues. So the first question is, how is chronic pain different in women? There are 3 ways of thinking about this. First, some forms of pain actually only seem to occur in women, such as dysmenorrhea, endometriosis, labor pain. Those are relatively obvious, and these types of sex differences are described as sexual dimorphisms. Other types of pain may occur in both sexes, but may manifest differently or might be mediated by different mechanisms in women versus men. These are what we refer to as qualitative sex differences, and I'll give you some examples of those later in the session. And then finally, there may be sex differences in pain processing or in pain treatment responses that result in different frequencies or magnitudes of pain among women, resulting in a scenario where women have more pain or less pain than men, and these are what we typically think of as sex differences. These are quantitative sex differences. I'd also like to touch on a few myths about sex, gender, and pain that exist. The first is that sex and gender are synonyms. In fact, in the literature, we distinguish between sex and gender in that sex refers to fundamental biology. You are either male or female based on your anatomy and your chromosomes. Gender, on the other hand, while influenced by sex, is also influenced by other factors such as socialization and how you are reflected in the society in which you find yourself. So gender includes more of a psychosocial and sociocultural component in addition to the influence of sex. Another myth, in my opinion, is that sex differences in pain are due to reporting biases. The implication of this is that either men are underreporting pain or women are overreporting pain. I find that not to be the case at all, and we, in my opinion, have very legitimate reasons for sex differences in pain, which we'll discuss. Also, there is some information out there that would suggest that sex differences in laboratory pain responses in humans are inconsistent and small in magnitude. I'll try to convince you otherwise. And that finally, gender roles are determined exclusively by environmental factors, particularly social learning. And to that point, a recent review by a well-known neuroscientist in the area concluded that human gender development begins before birth and is influenced by levels of testosterone prenatally and perhaps neonatally. Sex-type play in childhood relates to levels of testosterone before birth, and evidence indicates that the prenatal hormonal environment also contributes to variability in sexual orientation, gender identity, and some, but not all, personality traits that differ on average for males and females. The point being that it's not just social influences that drive gender roles, there are also fundamental biological contributors. And this leads to the fact that understanding sex, gender, and pain is best conceptualized in the context of the biopsychosocial model of pain. And this model suggests that the experience of pain is sculpted by complex and dynamic interactions among biological factors such as hormones, genetics, psychological factors including mood and pain coping, and social factors such as gender roles and potential biases that men and women may face in the healthcare setting. Understanding the importance of all three sets of factors is critical to understanding sex differences in pain. So now let me get to some of the findings on sex differences in clinical and experimental pain responses. You see there on your screen a table from a recent review article that Dr. Riley and I published back in 2009. And this is a table presenting the prevalence of chronic pain in population-based samples from different countries. And in bold, you see the findings in which there was a significant sex difference in prevalence, and the non-bolded numbers show non-significant findings. But what you'll notice is that for all of these studies, the percentage of women reporting chronic pain was higher than the percentage of men, even when the findings weren't significant. So what we see here is a consistent pattern of results with women reporting higher frequency of chronic pain than men. The magnitude of the sex difference varies across studies, potentially due to methodological factors, but this attests to the consistency of sex differences in clinical pain. Another depiction of these results is shown here in a figure that derives from a paper by Jeff Mogul published last year. And this shows sex differences in chronic pain prevalence across different categories. You see back pain, migraine, musculoskeletal pain, neuropathic pain, so on and so forth. As the bars go up into the pink space, that shows the excess prevalence in women. That is the extent to which women reported more pain than men. As the bars go down, and as we see only one bar goes down, that refers to excess prevalence among men. Now we see bars of varying height, but the direction of